I'm Dr. Alan Pearson. I'm an optometrist, and I am giving this presentation as a representative of the new Eye Center for Children's Vision, Learning, and Technology. University of Washington Bothell Eye Center for Children's Vision and Learning and Technology is about 1 year old formally, but has its roots in kind of the activism that was responsible for passing the new mandated near vision screening that all public schools have to abide by. So that was one track of the activism that led to the passing of that Senate bill in 2016. And another track led to the establishment of the Eye Center at the University of Washington Bothell. And I have been involved since a more informal group got together called the Children's Vision Research Group. I've been involved with this as the clinical advisor or clinical director. I also have a private optometry practice, and I specialize in vision therapy. So I work with children and special needs, children with learning problems. I work with all ages. I typically don't do just basic pediatric eye exams. I'm more of a specialist, and I take referrals from pediatric eye doctors to address basic functional vision issues, eye coordination, tracking, lazy eye, the things that we're going to talk about here today. And I have clinics in Bellevue and Bothell. So today we're going to talk about the vision issues impacting development and learning in the birth to 5 population. So we're going to concentrate on that early range, even though a lot of what we're talking about at the Eye Center is about school screenings. There's a lot of things that could be looked at and detected before kids get to kindergarten. Some of the learning objectives that we're going to focus on are understanding the important vision issues that we need to find and address in that birth to 5 range. So I hope everybody leaves this presentation with a good understanding of what the important vision issues are. We're going to talk about screening tools. What kind of tools will allow you to find some of these common vision issues that impact kids in the birth to 5 range? We're going to clarify some of the confusing issues and myths that some of the messaging that goes to parents. And we're going to connect with resources that can assist in solving some of these difficult situations and access to eye care. Okay, so let's get right into things and start talking about the common vision issues birth to 5. So here's just a general statement about vision loss, and a lot of the issues that we face that we want to screen for are trying to prevent some sort of vision loss. So vision loss means that a person's eyesight is not corrected to the normal level. Vision loss can vary greatly among children and can be caused by many things. We're going to learn about some of the things that can cause vision loss. Some of those things, if we have a big statement about what those might be, we could categorize those into damage to the eye itself, or maybe it's not shape, so structural issues, or neurological. So there's this physical, structural issues, and then there's those neurological or functional issues. The 2 big categories. Now, if we look again here at the CDC, Centers for Disease Control statement, they list some of the common vision issues in that birth to 5 range. Well, excuse me, not in the birth to 5, just common vision issues in general. Refractive error, age-related macular degeneration, cataract, diabetic retinopathy, glaucoma, amblyopia, strabismus. And we can kind of divide those into more physical or structural issues and neurological or functional issues. It doesn't mean that some of the physical structural ones, they might have neurological aspects to them, but they're mostly due to physical structural changes in the eye. Now, I've bolded the issues that are common in kids, okay? And the non-bold items are more common in adults, more age-related, like age-related macular degeneration. So refractive errors, amblyopia, and strabismus. We're going to talk more about these. So if we then go to the Prevent Blindness website, here's another list of eye problems in adults and children. And again, what I've done is bolded the ones that are common in kids. Amblyopia, color blindness, conjunctivitis, pink eye, refractive error, strabismus. Many of the other ones are more adult-related issues. Doesn't mean they can't happen in kids, but they're not very commonly seen in kids. Another way to kind of look at this big picture of vision issues in kids is to look at it from an ocular or cortical. Again, it's kind of the same physical, structural versus neurological, functional issues. Ocular issues are typically found in eye exams as some sort of abnormality in the vision exam testing. Cortical typically are presented through some sort of behavioral response. It's a neurological. So everything can be normal in the eye exam. Normal eyeball, normal structures, but behaviorally, the child is not functioning in a way that we would say they have normal vision. And this is where cortical vision impairment, CVI, kind of emerges. There's a lot more talk about CVI in the special needs kids and cases. And the eyeball is normal, healthy, but there's some sort of neurological reason why they can't use the information that the eyeballs bring to the brain in order to function in day-to-day life. So what I've done at the Eye Center is I've looked at the research, some of the sources that I shared with you and a lot of other research reports, and I've developed a classification or a categorization of common vision issues, which I'm going to talk to you about here today. And you'll see that there's some of the same issues that were highlighted or bolded in some of the prior slides. Eye health issues, refractive issues, strabismus, amblyopia. Okay, but then there's some other ones that weren't listed. Orientation and stability issues, binocular instability issues, visual information processing issues, and saccadic praxis issues. And when we're done here, you'll understand kind of what I mean by each of those categorizations. And I find that this is useful as a way of thinking about vision, to put the various conditions that can impact kids into one of these categories. It's not necessary that it has to be done in a certain way, but these kind of categorization schemes can be helpful in organizing what we do. We can kind of put different conditions in different realms, and this then helps us decide how we deal with issues, whether we're trying to design a vision screening to identify issues or treatment to address issues once they're found. And again, if we look at these common vision issues from that physical, structural issues and the neurological function, the first two, eye health conditions and refractive or optical conditions, tend to be more physical or structural, whereas strabismus, amblyopia, orientation instability, binocular instability, visual information processing tend to be more neurological or functional. So we're going to go through this list and talk about each of these conditions and issues. And specifically, while we go through them, we're going to talk a little bit about visual screenings. Okay? Because visual screenings are what we want to do in order to identify and bring kids to the attention of parents and doctors and so forth that may have issues that need to be addressed. So we're going to ask, do traditional visual acuity measures detect the condition? And are there better screening measures to detect the condition? And then we can talk a little bit about what tools and techniques you can use, especially in that birth to 5 range. So first of all, health conditions. These are usually structural. This is just a list of some of the possibilities. Drooping eyelid, cataracts. Cataracts can happen in young children also. Conjunctivitis, red eyes. A uveitis is an inflammation in the eye. So it usually has a red eye also. Cellulitis, another kind of inflamed eye that's very red. Blocked tear ducts, tumors, styes or lumps and bumps. Nystagmus, a little jerking eye movement. Color blindness. Okay. A lot of these just have normal visual acuity. You can see just fine. But some of them also affect visual acuity. Some of them only, you got conjunctivitis for a couple of weeks, but it's not going to affect your vision on a long-term basis. So a lot of these, you can know that there's something wrong for an eye health condition mostly by observation that something's out of the ordinary. So screenings don't function very well to identify eye health conditions. The purpose of a vision screening is usually not to identify the presence of a red eye. Many of the kids might have a tumor, which could be very important, but it might not affect visual acuity. So screenings aren't going to detect some of even the serious vision, eye health issues that may be present. Okay? So distance visual acuity, they pass. Near vision acuity, they pass. Okay? So big red X vision screenings don't do well for eye health conditions. So we're going down our list. Here's our scorecard for common vision issues. And in the traditional acuity-based screening, the reds are going to be inadequate and greens are going to be, we can get that from our traditional screening. So eye health conditions, it's not very good for acuity-based screenings. So now let's talk about eye optics issues. This is like nearsightedness, astigmatism, farsightedness. We're going to go over each one of those so you understand what they are. But these are the eyeglass issues that are corrected with a prescription eyeglass prescription, usually. So nearsightedness. Nearsightedness is a condition where you can see well up close, but you can't see well in the distance. Okay? It's also called myopia, is the medical term. So you're going to fail a distance visual acuity check, but you could pass a near vision acuity check. So you might be able to see the fine details just fine. I can see them fine without my glasses on. I'm nearsighted. Okay? But if I pull it out here, it suddenly gets blurry. So nearsightedness is a situation where the eye has kind of a focus up close. That's where everything is perfectly in clarity without having to exert any focusing effort to see sharp and clear. The system is relaxed up close. If you extend further away from that point of relaxation, everything's blurry because the muscles and system of the eye can't relax more than you can maximally relax. I could contract a muscle, but I can only relax it so far. So nearsightedness, there's no way to internally compensate for nearsightedness to see things sharp and clear in the distance, because you can't relax the eye more than its maximum amount. And the maximum amount is at a near point distance. When the individual looks at something up close, closer than that near point, then they have to exert some effort to focus the eyes. Then they contract the little muscle and bulge the lens in their eye to make things sharp and clear. Okay? The nearsighted person gets to that focal point at a certain distance, and the amount of nearsightedness determines where that distance is. The higher the nearsightedness, the closer it is. The less, and it's a logarithmic scale, so if you go from 0 to 1, you go from infinity all the way up to about a meter. And then when you go from 1 to 2, it's like half a meter, 2 to 3, and then it gets quite close, okay, very quickly. Okay, so if we look at the research, if we look at all the research around myopia, myopia doesn't relate much to developmental learning related problems. In fact, there's more of a correlation with higher achievement than there is with lower achievement and lower developmental issues. Okay? And when we watch any movie, TV show, it's the nerd that has glasses on, right? So stereotypically, we associate, nearsightedness with high achievement. Our traditional visual acuity checks, distance visual acuity, near visual acuity, they'll detect nearsightedness. So we give them a green check. It works out. Eye optics issues called astigmatism. This is where you have a misshapen part of the eye. It could be the cornea, the front of the eye, or it could actually be the lens right behind the pupil of the eye. Okay? But things are not perfectly round. They're shaped more like an egg or a football rather than a perfect sphere. So it tends to stretch. If you think of like silly putty, you take that image and you stretch it out. That's kind of what astigmatism does. It blurs things. It's corrected through an eyeglass prescription. So but you're going to, if you have a significant amount of astigmatism, you're not going to see well in the distance, and you're not going to see well up close. It's going to affect all distances. So you're going to fail your distance visual acuity measurements in your screening. You're also going to fail your near vision. So screenings are going to detect that condition pretty good, traditional visual acuity screenings. Farsightedness, also called hyperopia, the medical term. Hyperopia is a condition, it's just the opposite of myopia or nearsightedness. Remember, with myopia, you're completely relaxed and you're seeing well up close. With a farsighted individual, if you are looking at a star in the sky about as far away as you can see, that's like infinity, right? The system has to contract the muscle and bulge the lens in order to see that star clearly. It has to work to see sharp and clear. Now that focusing mechanism is supposed to be used up close. So when you look at something up close, you've already used the focusing system this much for the distance. So now you have to use it twice as hard for up close, or 3 times or 4 times. All depends on how much farsightedness you have. So farsightedness takes effort in order to see sharp and clear. Nearsightedness is without glasses on. Nearsightedness is almost effortless seeing for up close relative to farsightedness, which is effortful. So I can hold on to this, in this way, or I can hold on to it like this. I'm accomplishing the same thing. This is just a whole lot more effort than this is. So farsighted individuals have to exert an incredible amount of effort to focus and see. But they can do it. They can see sharp and clear in the distance, and they can see sharp and clear up close. For that moment of the visual screening, they just contract the muscle, focus those letters in, call off the letters, done. Show them the near point card. Contract a little bit more, focus those letters, call them off, done. So they can pass the distance visual acuity and they can pass the near visual acuity test. But if we look at the research, by and large, most of the research suggests that farsightedness has more of an impact on development, more of an impact on learning. And it's common sense. You can imagine if you have to work really hard to see, you're not going to want to necessarily engage in all those near activities that our culture demands. If you don't have as much learning opportunity, you're not going to achieve as well. Okay, so you can look at the last little thing. Levels greater than 1 diopter of hyperopic anisometropia, 5 diopters of isometropic. Those are when the eyes are different, create amblyopia. Okay, so, and you can see there's a lot of other comments about strabismus and amblyopia. So these other conditions we're just going to talk about, there's a lot of, there's a relationship between farsightedness and some of these other issues. Not so much with nearsightedness. Nearsightedness doesn't cause strabismus and amblyopia, but farsightedness can be a cause of it. I'll talk a little bit more about when we get to that strabismus part. So our screening, our traditional acuity checks, they fail when we're looking for hyperopia or farsightedness. Yet, that's the condition that should be detected because a significant amount of farsightedness is going to have more impact on development and learning. And it could be the cause of strabismus or amblyopia. So things are backwards. So, green, nearsightedness, myopia; green, astigmatism; red, farsightedness, because it has a higher impact in learning. Visual screening alone doesn't often detect significant hyperopia. What do you need to do in order to detect? You need either, in your screening, you need either what are called a hyperopia screening lens flipper, like this, $20. Or you need a device like this, which is $7,500. Most schools are using this right now, okay? So I'll talk a little bit more about it.
The child has to participate with the cheaper one, right? Be able to follow directions.
Oh yeah, and you have to be able to read an acuity chart, and it doesn't mean you can do symbols, but you have to be at least about 3 years of age. a developmentally kind of normal 3 years of age. You know, if you're still nonverbal at 3 years of age, you still have trouble with these.
Is the spot screener good for the elementary school age? 'Cause I
Oh
use
yeah,
it
and it's great
preschool.
for 6-month-olds too.
Yeah, I use it for the younger ones, but is it as good? Because of course it doesn't give you the acuity.
No, and that's what you're going to learn is that there's limitations to the spot screener. It's a great tool if you understand what it can detect and what it can't. And that's some of the myth, you know, is, wow, here's a device that does everything we need to in vision screening. It's a great addition to the toolkit, but it's not an all perfect, you know, device. All right? And that'll be really clear once we get through this list. So refractive or optical conditions, I give that a down score, red, because our traditional screenings do not detect the most significant aspect that can affect child development and learning, hyperopia. So strabismus are eye turns. Inward, upward, downward, could even be rotational. That's called cyclotropia. Okay? It can be very obvious, or it can be very subtle. You don't see it. Everything looks normal from the casual observer looking at the eyes. And it can happen all the time, or it can just happen occasionally. So there's so many different types of strabismus. And as I said, strabismus or eye turns can be caused by the need for eyeglasses. Let's think about that for just a second. Remember when I said farsightedness is a condition where you have to use the muscle and lens inside of the eye to make things sharp and clear. And remember I said that that focusing system is really meant for focusing up close, not for distance. So when you use your focusing system to make things clear in the distance, you're using it to a certain extent more when your power is, the farsighted power is higher, okay? And when you look up close, you're having to use it twice or 3 times as hard. And I said, you know, it's like this. Well, neurologically, we're wired up so that when we make the eye focus, it sends signals to the muscles near the nose, the medial rectus muscles, okay, to pull the eyes in. Because when you look up close, you also have to converge the eyes, cross them to look up close. So if you're making your eyes focus, it sends signals to make the eyes cross. Now, if I have my arm here and I have muscles on this side, and I send signals to this set of muscles, my arm will move in. If I don't want my arm to move in, I've got to send equal but opposite signals to the muscle on this side to keep my eye in one place, or my arm in one place. And this is what happens with the eye. When you send signals to the medial rectus muscles, because of the focusing, if you don't want the eyes to actually cross, then you've got to send signals to the lateral rectus muscles to keep the eyes in alignment. And the more your farsightedness, the higher the power, the more you have to compensate with those signals on the lateral.
So if somebody's squinting because they're trying to see, what is that indication?
Well, squinting can be kind of like, you could say, a motor overflow. They're just, you know, trying to exert so much effort to see that they're trying to send signals to the focusing and to the eye alignment, all right? And it happens to then squint the eyes. That could be one thing. The other thing is that when you look through a tiny little pinhole, you can see clearly. even if your optics aren't. So by squinting, you limit the light coming into the eye, and you kind of resolve some of the optical problems. So yes, so squinting is a behavioral sign of some sort of problem with vision. It could be optical, or it could be strabismus, that the individual is trying to find that position of tension that kind of keeps things together. And this is the dilemma that kids that are very young have when they have high amounts of farsightedness. If they make their eyes focus, it sends signals for their eyes to cross. If their eyes actually cross, they'd see double. They don't want to see double, so they have to relax the eye pointing, but then things go blurry. So there's a lot of kids somewhere between 1 and 3 years of age that suddenly have eye turns that emerge. And what tends to happen is around that age, they figure out that they really would like to see things more sharp and clear. So they sacrifice their binocular vision because they can't have it both ways. They can't have it single and clear. And they prefer to have it clear because in our culture, we value identification and detail. So they learn, let's be oriented towards the detail, let's get the information in, forget about binocular vision. So they let the eye turn. Then at that point, the parents see that there's a possible vision issue. Then at that point, they go in to see the doctor. And the doctor then measures a high amount of farsightedness, prescribes a pair of glasses. This relaxes that focusing, and now the child can get things both clear and keep things single. And if everything works out, the child then returns to normal vision development, but with a pair of glasses. If they've had too much development in the, with the eye cross, then sometimes it's hard to just throw on a pair of glasses and solve the problem. If you could put the pair of glasses on before the kid had that dilemma, that solved the dilemma by crossing the eye, maybe you could prevent the eye crossing in the first place. But you've got to know that hyperopia is there, which means you've got to probably detect it in some screening or eye exam that happens pretty early in a child's life. Okay? Strabismus can be thought of, you can use a little metaphor of like a train track to think about strabismus and in this dilemma that kids have when they're developing. When we're born, we're not hardwired to have our eyes work perfectly together as a team. We have to develop. There's hard wiring that is there ready for experiences in the world which will solidify that binocular function, but you have to have those good experiences. So if you think of it like a train track has two rails, the right and the left. Okay? Think of it, right eye, left eye. But you also have the ties that hold the rails together. And as you grow and develop, it's like you're laying down the train track. The path is there. That's the brain being ready for normal binocular development. It's like the path is there. But you have to put those rails down and you have to build those ties of binocular two-eye coordination through normal developmental experiences. And this happens generally most importantly in those first few years of life. Now, what happens if you have some sort of blockage in that path? all right, then the brain and the developing child needs to deal with the situation in some way. And what that usually means is to build one of the eyes, develop one of the eyes processing and so forth, and neglecting the other. Or you develop both, but you don't build any ties. So if you could imagine a rail just kind of going off onto a side path, it just has one rail, this is kind of like a strabismus. The eye turns, okay? And if you could imagine one of those tracks kind of developing and the other one getting neglected, then we have the problem of amblyopia, which we're going to talk a little bit more in just a second. So strabismus usually occurs very early in life when there's some blockage to that normal development of the child's two-eye coordination. Okay? How do you detect strabismus in a screening? Well, there's all different kinds, as I said. There's sometimes strabismus, there's all of the time strabismus, there's subtle strabismus that you can't see much, and there's very easily observable strabismus. Okay? These devices will also detect more serious strabismus, but it's almost to the point where you could observe it. If you are a keen observer, so the subtle strabismus, not necessarily. It's not going to necessarily pick it up. In the only occasional time, the intermittent, sometimes strabismus, no, because at the moment they may be using their two eyes together as a team. So another tool that you can use is, it's not perfect either, but it's a lot better than acuity measures, because doing this with one eye covered and the other eye covered isn't testing two-eye coordination at all, right? And you can't really test, under 3, with reading symbols, and that's tough. So how do you test for strabismus? Well, if a child has normally developing binocular vision, then they will be able to see binocular 3D depth. Okay? And there's all sorts of tools, but one fun thing that you could have hanging around your developmental centers and so forth is having some fun 3D books and games and things like that. I'm going to pass this one around. There's even tools which you don't need, eyeglasses, special eyeglasses, because all those kids with sensory processing don't want to have anything near their face. Okay? They might not even want to wear it. I can't sometimes even test them because they don't want to wear a glass. So you have to use a tool that doesn't need a pair of eyeglasses. And there are those. You've kind of seen those things. You kind of look at it and things pop out because of the way the little plastic is made. So I'll pass this around and you can kind of explore. If you see 3D, you'll find kids, wow, they have an aha, wow. And if they don't, what's the big deal, All right? So these are some of the probes that you can use. You're probably not going to do this in a formal vision screening, okay? But it's a good way of having little probes that you can just, in day-to-day activities, you can kind of get a sense that something is not quite right with a child's. Okay, so let's... In screening tests, there's more formalized, screening tools and so forth for stereo vision. So strabismus doesn't score very well for our traditional screening tools. Amblyopia is also known as lazy eye. Some people think of lazy eye as the eye turning, the strabismus. So most parents that come in, they say, my child has a lazy eye. What they really mean is my child has an eye turn, a strabismus. But amblyopia is a condition where one eye's development is not at the same point as the other eye. So visual acuity usually is the measure of that. Visual acuity, sharpness of sight, is blurry in one eye relative to the other, even with the best eyeglass prescription on. So it's not an optical issue. It's a blurry, it's because that channel is not developed. That eye is not developed compared to the other eye. So it's in this train track analogy, it's when one eye's train gets a monocular, one rail goes way off into development, and the other one lacks, it stays behind. So one eye's visual acuity is good, the other eye is bad. Okay? That's amblyopia. And it most often impacts visual acuity or sharpness of sight. But development is across the board. They don't have good eye movements in that eye. They don't have good eye pointing, eye focusing. They don't have good visual motor integration from information from that eye. So it's not just visual acuity. It's a lot of developmental aspects of just using information from the eye. But visual acuity is usually the best measure for amblyopia. But then again, it's very hard to measure sharpness of sight in kids that are less than 3 years of age. So many times, doctors have to assume that amblyopia will develop when there's some factor like strabismus present in a young child younger than 3 years of age. So sometimes very young children are prescribed patching or atropine drops or other things to prevent amblyopia development, but it hasn't yet necessarily been diagnosed as being present yet because the doctor can't know for sure through a visual acuity check that there's actually a difference. Sometimes the doctors prescribe patching not just on one eye, but do a little bit on this eye and a little bit on that eye and so forth, because they want to make sure both of those channels are developed, both of the eyes are developed. So let's give this eye some developmental work. Now let's put the patch over here and develop. So we got those rails kind of more equal. But doing a patch doesn't do anything to develop those ties that hold the two eyes together. So there's no binocular development going on. So amblyopia impacts both your distance and your near vision acuity. So screenings of visual acuity can detect amblyopia. Now, amblyopia can be caused by that strabismus. If one eye's turned in or out, what the brain does is it chooses to ignore the information from the eye that's turned. It suppresses, turns off information. It's not a total suppression of everything that comes into the eye. You still have peripheral vision, but the central detail information is suppressed so that the child doesn't see double. But that active suppression or turning off of the information creates the amblyopia. All right? Amblyopia can be caused by a difference of optics in the two eyes. Let's imagine one eye has no nearsightedness, no astigmatism, no hyperopia, The other eye has a really high amount of one of those conditions. There's this big difference between the two eyes. So the child gets the good eye sharp and clear and can identify targets, but they never bother to see clearly with the other eye, so that eye doesn't develop its vision. So the train tracks separate, okay? And you have an amblyopia. You can actually have both eyes being amblyopic. This is the kid that has like a really high amount of astigmatism, myopia, farsightedness, hyperopia, in which case neither eye can see sharp and clear. There's just no way to optically get a clear image on the back of the eye, so neither eye develops really well. I had a case a couple of years ago of a kid that had plus 10. Now plus is hyperopia or farsightedness. So plus 10 is a lot of farsightedness. And this kid came to me at about 6 years of age because when he got to kindergarten, he couldn't see anything on the board that the teacher was presenting. So it was odd vision behavior. He wasn't able to see it. Okay? But he had gone through 6 years of life, well-child visits to the pediatrician, never had an eye exam, passed whatever screenings, that supposedly were done. But when measured at that kindergarten, first grade level, he had about 2,200 vision. Yet this kid went out and he played, he rode his bike, he did skateboard, he was very active. But probably parents weren't very centered on literacy and so forth. Because if they had sat him down to look at books and things like that and been a keen observer, they probably would have seen, there's something about this kid's vision. But if he seems normal, going out, playing, doing things, some parents can be just happy with what they see as a normally developing child. So the parent was just totally unaware that anything was the case. And the kid did not have any eye turn. Remember I said when you have a farsightedness, you try to make things focus and that sends your eyes in. Well, this kid had so much farsightedness that even focusing the eye wasn't going to make things sharp and clear. So he never bothered to resolve that clear vision. So he never developed the strabismus or the eye turn. So, but he had amblyopia in both eyes because neither of the eyes, he never bothered to see clear, so neither of the eyes developed. So those rails got blocked at a certain level and he couldn't see better, more than 20 in each eye. So amblyopia can be, there can be a lot of different types of amblyopia and in different causes. There are other more rare causes, like if you have a congenital cataract or something that blocks vision, you're going to have, an amblyopia. Again, I found a child once at 7 years of age, first eye exam, congenital cataract, pretty much blind in that eye. I mean, if you take a photograph of that child and you see one eye light up in the pupil and the other eye is kind of dark because there's no light goes in and out. So that child had the cataract surgery, take the cataract out. So, but that eye never developed more than 2,400 vision because by that time that channel was so neglected in terms of development, and the brain had just put all of its energy into the other eye and seeing. There's cases of congenital cataracts in both eyes being removed when an individual is an adult and suddenly now they have the information coming into their eyes, but they've had 20 years of being blind. Well, they don't learn how to see. They don't appreciate seeing. It's just noise. It's chaos. So a lot of these individuals just prefer to cover their eyes, and it's interesting. It's kind of a new experience, but it's not something that's real comfortable for them.
So the amblyopia is a lack of development of
Lack
the eye,
of
whether
development.
it's both or one less than the other.
Right. So it's neurological, functional. There's nothing. There's some reason, so there might be a structural, physical reason for it, but it is a lack of neurological development because that pathway is meant to develop binocular vision, and there's some sort of blockage. So those rails separate, amblyopia, or they just don't develop.
Can older children though gain some better vision, like with children who are deaf? You know, the later the cochlear implant, the less benefit they get, but sometimes they can get some.
Yes, I mean, it's not that so you can get something out of vision, but it's not the same because things just haven't developed.
So then the kiddo who had the 2200 vision in both eyes,
Right.
were you able, was there
20/30 vision was the outcome. Wearing glasses. With glasses and therapy and so forth. But he never developed a cross eye, which is great. So the kids that have +5 or 6, half of, they are the ones that develop the cross eye because they can get it clear by letting their eye cross. So.
Is there a certain amount of time that's recommended for patching or drops? And then at some point, it is what it is and amblyopia isn't going to resolve itself anymore?
You can improve sharpness and sight. You can do developmental work on, whether you use a patch, whether you use traditional vision therapy. There's new techniques using virtual reality headsets and so forth. You can make, the research is very clear, you can make, if you're 70 years old, you can still make changes to the brain. But it's not quite the same kind of development that occurs, really early on. So it's easier the earlier you deal with it, or if you prevent, things from developing in the first place. Again, if you think of the train track, okay, you've developed this one-eye train track. If you go back, what you have to do to develop the two eyes, you have to almost go back developmentally to the point where it's deviated and start building the two-eye coordination and the rail and the ties and so forth to get to the goal. But the thing is with our nervous system is that this other rail, the monocular rail, never goes away. It's like once you know how to ride the bike, you always know how to ride the bike. That's in there, in the system, neurological connection. So these kids can sometimes switch. Now they have a binocular vision system, but they could switch over to this monocular rail if it suits their purpose for the moment. So their eye turns and they don't see double and so forth. And so it never goes away. So what we want to do in therapy is really develop that binocular vision system so that it becomes the main track, the main path. And this one over here gets rusted and overgrown and so forth. Right? Did that answer your question? I know you wanted to ask me.
I was going to say, regardless of the age that you start, is there a length of time that, like, once it's done for 6 months or a year or 4 years, that's kind of where it's at, and that you don't expect much more development, or you can just keep trying indefinitely?
So when you have a really young child, you could patch, or some infants, if they have some eye health issue with their eye, they're normally developing, but there's something that blocks their vision. It doesn't take very long for an amblyopia to start to set in. As you get older and older, you're going to have to do more and more aggressive patching and so forth. So the typical thing is, 2 to 4 hours, somewhere in that range, okay? And 7 days a week, or atropine drops or something like that. And, but when you get older and older, you're probably going to need to start doing more active vision therapy in order to get more results. You might get some results from the patch to a certain extent, but then you have to say, okay, you got this far. If you look at the graph, we're plateau. Doing more of the same is probably not going to, And you have to also think these patches, a black patch or something like that, it's not building any of the ties that help the two eyes. So there's a lot of alternatives. You could have like a film over one eye that blurs the good eye, right? So that the other eye does more work, but it doesn't prevent the peripheral vision. So then the individual can keep their two eyes working together as a team while they're developing the good eye. And like the virtual reality, what they do is they set up games. With the virtual reality, you have one eye that sees one screen, the other eye sees the other screen. So the software sends part of the game to one eye and part of the game to the other. So if you really want to play the game, you've got to use the two eyes together as a team, and you've got to process information from the weaker eye. And that can be very motivating. So the other part of it is motivation. If you're just wearing your patch and you're passively watching TV programs, you're not going to see much results. If you're doing active things while you're patching, eye-hand coordination, that could be playing a video game, because a lot of those, you pick up details and so forth. But playing, with eyes and hands is really good. Then you're going to get more and better results. Yep.
So are you saying that every condition can be reversible? Because we had a particular little guy, and he's just gonna go into kindergarten. He had, swirly eyes. It
Yeah.
was pretty severe. And there were real obstacles for these parents to get him to the doctor. And for some reason, they were under the impression that we gotta get him in there before 5 because it could be irreversible. Is that?
The brain's going to develop regardless. So yes, time is of the essence. The earlier you can get these things, the more likely it is that you can prevent them. So it is true that, it's not so much that it's irreversible. You can do things, but it just takes a lot more effort. And if it takes a lot of therapy and this and that, some people just don't have the resources, the time, the energy, the commitment to do that. It isn't that you can't do it, it's just, if it were caught earlier, maybe it wouldn't have emerged in the first place. So screenings can detect amblyopia, but they're only really good for children in that it can call symbols on a chart, meaning 3+. So these devices do not detect amblyopia.
I think I had one reading that it said it was amblyopia.
No, it detects the problems that can cause amblyopia, like big differences in refractive error or strabismus.
But I think, and that called it amblyopia.
Yeah, it's not. It's what they call an amblyogenic factor. It's something that can cause amblyopia. These do not detect amblyopia. So amblyopia I put as green because visual acuity, traditional visual acuity, but only if you test each eye. If you test binocular, you have to check the difference between the two eyes. Okay? For more information and resources about vision issues in children, visit www.educatingyoungeyes.org or www.wellchildvision.org. A full presentation on this topic is available at the School Resources tab of the educatingyoungeyes.org website. The presentation is titled Vision Issues Impacting Development and Learning, Birth to 5, presented by Dr. Alan Pearson at the 2018 Infant and Early Childhood Education Conference, May 3rd, 2018, in Tacoma, Washington.